Here is a case of grade 6 facial palsy. We are discussing here the facial nerve dual anastomosis. Why dual anastomosis? When the facial nerve is not likely to recover and is a complete transection, is a flaccid paralysis. If you give two inputs to the facial nerve from mesenteric and hypoglossal, the resting tone and the smile is better than the single coaptation anastomosis. This 55-year-old male operated case of right acoustic neuroma. There is a complete transection of a facial nerve occurred during acoustic neuroma surgery. Developed House-Brackman grade 6 facial palsy following surgery. 2 months after the surgery, we decided to go ahead with the reanimation to restore the facial symmetry, eye protection, and the dynamic smile. The plan of the surgery is dual innervation using mesenteric and hypoglossal, harvesting the sural nerve graft, end-to-side hypoglossofacial anastomosis, fascia lata sling, and the static sling in addition to the nerve anastomosis. Temporary tarsorrhaphy is already done by ophthalmologist. The first is to identify the mesenteric nerve. The mesenteric nerve has a fixed landmark which is 3 cm anterior to tragus and 1 cm below the zygoma. After dissection for the mesenteric nerve, look at the diameter of the mesenteric nerve and find the branch of the facial which is equivalent to the diameter of the mesenteric nerve. Now you can see here the mesenteric nerve and the branch of the facial which is the equal diameter of the mesenteric nerve is anastomos. So anastomosis in progress using 9-ethylone under high magnification. At the end of the anastomosis, we also reinforce this using the fibrin glue so that it reinforces the anastomosis. This anastomosis is over. Then we will proceed with the facial nerve trunk to the hypoglossal anastomosis. For that, we need a cable graft, and the donor site could be either a sural nerve or a greater auricular nerve. A sural nerve has a better diameter, so our preference is to take a sural nerve. So the facial nerve main trunk is disconnected from the xylomastoid foramina. Sural nerve is harvested. Since the sural nerve is a sensory nerve, our preference is to do a reverse polarity because we want this to work like a motor nerve. Facial being a motor nerve, we have reversed the polarity. Now the proximal end of the sural nerve is anastomos with the distal end of facial nerve. The anastomosis is reinforced with a fibrin glue. When it comes to the hypoglossal nerve, the structure which comes in the way is posterior biliary of digastric. We disconnect the posterior biliary of digastric in order to get a proper access to the hypoglossal nerve. Hypoglossal nerve is end to side anastomosis. So we have to have a 50% transaction of the facial nerve, and 50% integrity allows near normal hypoglossal function of the tongue protrusion. Now see the anastomosis happening. A groove or notch is made, and that is anastomosis with the sural nerve graft. This anastomosis is wore and reinforced with the fibrin glue. Facial sling using fasciolata. It is a static reanimation for the facial nerve. So question is, when there is an anastomosis done, what is the necessity of fasciolata graft, facial sling? Till the anastomosis starts working, it takes nearly 8 months to 12 months. And this facial sling allows a symmetry till the nerve anastomosis starts functioning. Plus, the facial nerve function for the swallowing mechanism, food accumulation, is prevented by tightening effect of the fasciolata sling. So that is the reason fasciolata sling is also done, and the tarsography is done by the ophthalmologist already. This sling is fixed on the zygoma using the mini plate. This is how it looks at the end of the surgery on the same day. You can look at the hypoglossal nerve. Patient can protrude the tongue with slight deviation to the side.